You know that feeling when you step awkwardly and your knee just doesn't feel quite solid, like it might just buckle?
Yeah, that instability feeling, it's unsettling.
Exactly. And today, we're diving deep into one specific knee injury that can cause just that, a posterior cruciate ligament tear, PCL tear.
And the PCL, it's a real workhorse at the back of the knee.
Right. It's the main structure stopping your shin bone, the tibia, from sliding too far back.
We're talking significant stability here. The sources mention it provides something like 95% of that posterior restraint.
95%. Wow. And it helps with sideways and twisting movements too, right?
Absolutely. Varus, valgus rotation, it plays a role in restraining all of those.
Okay, so we've got our revision notes on PCL tears right here. And our mission today, really, is to pull out the essential info you need, help you nail this for revision.
Yep, we'll cover the definition, what causes it, the risks, how it actually happens inside the knee,
What else it might be confused with, who gets it, how it presents clinically.
how we diagnose it, management options, what to expect prognosis-wise, and any potential problems down the line.
And we'll try to keep it, clear, interesting, and definitely not overwhelming. Ready to jump in?
Let's do it. So, definition first. A PCL tear is basically an injury damage to that posterior cruciate ligament.
Simple enough. But how does that damage usually happen? What are the common mechanisms?
Well, it usually takes a fair bit of force. Think about a direct hit to the front of the knee.
Like the dashboard in a car crash.
Exactly. That dashboard injury is a classic, very common cause. Also, hyperextension, bending the knee too far backwards.
Ouch.
Yeah, and falling hard onto a bent knee, that's another big one.
What about sports? We hear so much about ACLs in sports.
PCL tears happen in sports too, definitely. Maybe not quite as commonly flagged as ACLs, but think contact sports, awkward landings. They're certainly up there.
And the notes mention hemarthrosis, blood in the joint.
Yeah, apparently PCL tears are found in over a third of acute knee injuries that present with hemarthrosis. So it's definitely something to keep on the radar.
And the impact. It's not just pain, is it? It affects activities.
Oh, for sure. Daily stuff, work, sports, all potentially limited.
Right.
And there can be long-term effects on the knee joint itself.
Okay, so that's the what. Let's dig a bit more into the etiology, the causes. You mentioned the direct blow.
Yeah, that direct blow to the anterior tibia, the front of the shin just below the knee, especially when the knee's bent, that's probably the most frequent mechanism.
Car accidents, contact sports.
Right. Football, rugby tackles hitting the front of the knee. Then there's hyperextension, forcing the knee backwards.
And the fall onto the bent knee.
Yep. Basically, situations involving significant force or trauma to the knee, high impact stuff.
Okay. So given those causes, who's particularly at risk? Are there specific risk factors?
Well, it kind of follows from the causes, doesn't it? Participation in those high impact or contact sports is a big one. Football, rugby, again.
Makes sense.
Trauma, like those car accidents we keep mentioning, just due to the high energy involved. And maybe, obviously, if you've injured your PCL before, or if your knee is already a bit unstable for other reasons, you're likely at higher risk.
Right. Prior injury often predisposes to re-injury. Okay, so we know what it is, how it happens, who's at risk. Let's get technical for a moment, pathophysiology. What's actually going on at the tissue level?
Okay, so fundamentally, the ligament is subjected to a force that's greater than its tensile strength. It just can't handle it.
So it tears, either partially or completely.
Exactly. The collagen fibers that make up the ligament tear. And as we said, the force is usually to the front of the knee, pushing the tibia backwards relative to the femur.
So that connection, that restraint is lost or weakened.
Precisely. And that posterior tibial displacement, that backward movement, is what directly impairs the knee's stability and function. It's interesting because the hamstrings naturally pull the tibia back.
So without the PCL holding it forward.
The hamstrings and even just gravity can cause that backward sag. The PCL is the main thing stopping that.
Okay, that makes sense mechanically. Now, someone comes in with knee pain, instability. It's not always a PCL tear, is it? What else should be on our minds? The differential diagnosis.
Absolutely crucial point. You've got to think broader. An ACL tear, the anterior cruciate ligament, is often top of the list, similar symptoms sometimes.
Pain, instability. Yeah.
Then you've got the collateral ligaments, the MCL and LCL on the sides of the knee. They can tear too.
Okay.
Meniscal tears, the cartilage pads within the joint, they can cause pain, clicking, sometimes instability.
Right.
Patellar dislocation and kneecap popping out definitely causes acute pain and makes the knee feel unstable.
Yeah, you know about that one.
And then just the broader category of knee joint instability, if the specific structure isn't immediately clear. And for more chronic pain, especially in older patients, you have to consider osteoarthritis.
Good list.
Yep.
So how common are PCL tears? What's the epidemiology look like, particularly here in the UK?
Yeah, specific UK-only data seems a bit scarce, actually. But the general consensus is they're less common than ACL tears.
Okay. Still significant, though.
Definitely. They tend to happen in those settings we discussed: sports, high-impact accidents. International figures suggest maybe 5 to 10% of all knee ligament injuries might be PCL.
So not rare, but maybe less frequent than ACLs, partly because the mechanism often involves higher energy.
That's a reasonable thought, yeah. The forces needed can be quite substantial.
Okay. So let's imagine someone has just torn their PCL.
Mm-hmm.
How might they present? What are the typical clinical features we'd see or hear about?
Often there's immediate pain, quite a bit of swelling usually, and that feeling of instability we mentioned.
That giving way sensation.
Yeah, exactly. Interestingly, unlike ACL tears where people often report hearing or feeling a distinct pop,
Yeah.
that pop might be less common or less noticeable with a PCL tear. It's not always there.
Good distinction. And can other things be injured at the same time?
Oh, definitely. PCL tears often occur as part of multi-ligament injuries. So the ACL, the collaterals might be involved. You can also get fractures, like small bits of bone pulled off near the top of the tibial plateau rim fractures.
So a thorough assessment is key.
Absolutely. And here's something a bit odd sometimes. Right after the injury, the pain and swelling might not seem that bad.
Really?
Yeah, some people might even be able to walk, perhaps a bit gingerly, but walk nonetheless.
So it could be missed initially.
Potentially, yeah. But the physical exam findings are usually quite telling.
Ah, okay. What are the key tests?
The big one is the posterior drawer test. You have the patient lying down, knee bent to about 90 degrees, foot stable, and you gently try to push the upper part of the tibia backwards.
And if it moves back more than the other side?
That's a positive test. It's considered the most sensitive clinical test for a PCL tear.
Okay. Posterior drawer. What else?
The posterior sag test, or
Yeah.
Godfrey test, you get the patient to lift both legs with hips and knees flexed to 90 degrees, supporting their heels. You then look from the side.
And you're looking for...
You're looking to see if the injured tibia sags or drops backwards compared to the uninjured side due to gravity?
Ah, I see. Gravity pulling it back because the PCL isn't holding it.
Exactly.
So physical exam sounds absolutely critical. What about other investigations? Imaging?
Exam first, always. Plus, getting that detailed history, how did the injury happen, the mechanism is so important.
Right.
Then imaging. MRI is really the gold standard for looking at soft tissues like ligaments. It lets us see the PCL directly, assess the extent of the tear, and crucially, look for those associated injuries. Other ligaments, meniscus, cartilage damage.
Makes sense. Any limitations to MRI?
It's generally excellent, but the sources mention it might be slightly less accurate for diagnosing older chronic PCL tears compared to acute ones. Still very useful, though.
And X-rays?
X-rays are mainly useful to rule out fractures, especially those avulsion fractures where the ligament pulls off a piece of bone, or tibial plateau fractures.
Okay, so we've done the exam, maybe got an MRI, confirmed the PCL tear. What next? How do we manage it?
Right, management. It really depends on the severity of the tear, whether other structures are involved, and the patient's activity level and goals.
So not a one-size-fits-all approach.
Definitely not. For many isolated, less severe tears, grade 1 or 2, maybe non-surgical management is often the first line.
And what does that involve?
The main goals are controlling pain, reducing the swelling, getting the knee moving again, and importantly, activating the quads.
Okay, how do we do that?
The standard stuff, initially, Pricer. Pain relief, rest, ice, compression, elevation, and then early rehabilitation.
Bracer, got it.
Things like electrical stimulation to help muscle function, or cold whirlpools can sometimes be used too.
What about weight bearing? Crutches, braces?
For really minimal injuries, weight bearing might be allowed quite early. More significant tears might need crutches for a bit. Sometimes, especially if there's a lot of instability or other injuries, a brace might be used, often locked in extension initially.
And you mentioned rehab being crucial, particularly the quads.
Hugely important. The focus in non-surgical rehab for PCL is often heavily on strengthening the quadriceps muscles, the muscles at the front of the thigh.
Why the quads specifically?
Because strong quads actively pull the tibia forward. This helps counteract that backward pull from the hamstrings and gravity that happens when the PCL is torn. They act as a dynamic stabilizer.
Ah, clever. Using muscles to compensate for the ligament.
Exactly.
Okay, so that's non-surgical. When might surgery be considered?
Surgery is typically reserved for certain situations, like those PCL avulsion fractures we mentioned where the bone fragment needs fixing back.
Makes sense.
Also, if there are tears in multiple ligaments, like PCL plus ACL or collateral ligaments, surgery is often needed to restore overall stability.
Okay. Multi-ligament injuries.
And of course, if someone has gone through a good course of conservative management, including dedicated rehab, but they still have significant instability or symptoms that limit their function, then surgery might be an option.
And what does surgery involve? Is it a repair or a reconstruction?
Usually, it's a reconstruction. The torn PCL is replaced with a graft tissue taken either from the patient elsewhere, like hamstrings or patellar tendon, or sometimes donor tissue.
And there are different ways to do this.
Yes, various techniques exist for drilling tunnels in the bone and fixing the graft. There isn't really one single technique that's universally agreed upon as the absolute gold standard for every PCL tear. Surgeon preference and experience play a role.
Okay, so after treatment, whether surgical or non-surgical, what's the outlook? What's the prognosis?
It really varies, depends heavily on the initial injury severity, any associated injuries, and probably most importantly, the patient's commitment to the rehab process.
Rehab keeps coming up as key.
It really is. But with the right approach, many people can get back good knee stability and return to their regular activities, even sports.
That's encouraging. What about outcomes for conservative management specifically?
Actually, conservative management for isolated PCL tears often yields pretty good results. Many patients report satisfactory knee function and manage to return to their previous activity levels.
But there are potential long-term issues. You mentioned osteoarthritis earlier.
Yes, that's the main long-term concern. There seems to be an increased risk of developing osteoarthritis in the knee later on, especially if there were associated injuries like cartilage damage, or if the PCL tear went untreated or unstable for a long time.
Right, so addressing it properly is important for long-term joint health too.
Definitely.
And are there any other specific complications to be aware of?
Well, linked to that osteoarthritis risk, some sources mention potential for chronic pain, specifically around the kneecap, that's patellofemoral arthrosis, or on the inner side of the knee, medial compartment arthrosis.
Okay.
And it's worth saying, the really long-term consequences decades down the line of a complete PCL rupture, even if treated, are still being studied. The picture isn't fully complete.
Understood. Okay, that's a huge amount of information.
Yeah.
Really useful. Let's try and cement some of that with memory tips, maybe some mnemonics.
Good idea. Revision aids are always helpful.
Okay, for the causes, maybe group them. Direct blow, hyperextension, fall and bent knee, sports high impact, accidents, like car accidents, maybe DHFSA.
DHFSA?
Yeah.
That could work. Linking the mechanism.
And for the key tests, think posterior. It's the posterior cruciate ligament. So the test involved posterior movement, push back, posterior drawer, or sag down, posterior sag.
Posterior, push back, sag down. I like that. Simple and direct.
For non-surgical management, the big rehab focus is...
Quadriceps.
Exactly. So maybe think quads for PCL, strengthening those quads is vital.
Quads for PCL. Yep.
And the differentials, maybe group them logically. Other ligaments, ACL, collaterals, cartilage, meniscus, bones joint alignment, patellar dislocation, OA, and the general term instability.
Yeah, breaking it down into categories helps avoid missing things. Ligaments, cartilage, bony alignment, general instability, good structure.
And maybe create little mental stories. Imagine that dashboard injury cause, then checking the knee and finding it sags back, test sag. Pushing it back confirms it, test drawer. And knowing the key muscle for rehab is the one in the front, management quads.
Yeah, visualizing the scenario can really help embed the information, linking the cause, the signs, the management focus.
So just to quickly recap the absolute must-knows, PCL is the main posterior stabilizer. Injury often from direct anterior blow or hyperextension. Key tests are posterior drawer and sag. Management often starts conservative with a focus on quad strength, but surgery has its place, especially for multi-ligament injuries or persistent instability.
Nicely summarized. And remembering that potential long-term OA risk is important too.
Absolutely. And that dedicated rehab is non-negotiable for a good outcome.
Couldn't agree more.
Okay, well, if you're deep in MSRA prep right now, we really hope this deep dive has helped solidify PCLtears for you. Made it a bit clearer, a bit more memorable.
Hope so.
For loads more high-yield revision resources, definitely check out MSRA.com. And for some excellent free materials as well, you can head over to freemsra.com.
Good plugs. They're great resources.
So, final thought maybe. The knee is complex, no doubt about it. But really understanding the role of each key structure, like the PCL, is a massive step towards mastering that musculoskeletal knowledge you need.
Well said. One ligament at a time.